Bridget Smith is a licensed clinical psychologist who received her PsyD in clinical psychology from James Madison University and her master's in sports medicine and psychology from the University of Denver. She completed both her clinical internships and postdoctoral residency at James Madison, where she specializes in trauma, eating disorder, body concerns, and student athlete and mental health. Currently, she coordinates the Sexual Trauma Empowerment Program at JMU and provides individual therapy to students presenting with a variety of concerns. She also co-facilitates the STEP support program. She provides supervision for clinicians in training, and prior to her current role, she worked as a clinician at Well Counseling Clinic in Philadelphia, providing outpatient therapy to individuals with eating disorders and body image concerns. And without further ado, I will introduce you to Dr. Smith, so take it away.
Hello, everyone. Thank you so much for having me today. I'm really looking forward to spending the next couple hours with you. My path to working, primarily with trauma, as you maybe can even hear in my degrees, a little nonlinear. So in reflecting as I was preparing for this and putting the pieces together, I think it makes a lot of sense. I originally, went to get my master's in sport and performance psychology, hoping to help athletes in their performance concerns, and quickly learned and had a deep appreciation for how nothing happened. So off the field situations, family concerns, relational issues are going to have an impact on the field, and wanting to be able to help people understand themselves and how they relate to others at a deeper level, which is why I went on to pursue my doctorate, in part because I was also really interested in understanding eating and body image concerns in a variety of different cultural contexts, and recognizing that that was more clinical in nature, sought out opportunities, in my doctorate training. And, as I was sitting with individuals talking about eating and body image concerns, just came to recognize kind of the overlap and at times just relationship between a history of trauma or a trauma occurring and exacerbating those symptoms, and really wanting to better be able to help those individuals and meet the client and individual where they're at to help them heal. So during my training, doctoral training, I sought out opportunities specifically with sexual trauma, and have found that I find this work to be both really hard and really rewarding. And so my hope today is that in this training, we'll go, Judith Herman stages of recovery, which is what I utilize when I am meeting with individuals who have a history of sexual trauma, and that we'll have a conversation utilizing a case vignette. I do have a PowerPoint presentation just with pieces that I think can be helpful. And I'm also happy to share afterwards. But as Gabrielle said, I'm really hoping this to be kind of an ongoing conversation. So I'll share my screen and power, and I'll pause to ask if there are questions or reflections, but also invite you to type your questions or reflections into the chat box. And then toward the end of the presentation, we'll use vignette and have a kind of, my hope is a larger group discussion on considerations for early treatment. So I'll go ahead and share my screen now. This is where I always seem to have the hardest part doing this. It looks like I am unable to screen. Oh, that seems to work. Okay.
Does it work now?
Yes.
Okay, cool.
And so the primary focus of today's presentation will be on stage 1 of Judith Herman's stages of recovery, which is really establishing safety. And so my hope today is just to have a conversation and talk about actual like concrete techniques that you can take away about what that actually means when we talk about establishing safety. My space. There's no. And so today the plan is to do a general brief overview about trauma-informed care, review Herman stages of recovery, but primarily our conversation and training is on that stage 1. How to kind of utilize and take this approach when assessing sexual trauma history at intake and early treatment considerations utilizing that case. So before we jump into sexual trauma and working with sexual trauma, I just want to take a step back and kind of the big eye, bird eye view picture of just trauma-informed care and the approach. This may be a review for many of you, but just recognizing that trauma-informed care is not a type of psychotherapy, but more an approach to working or interacting with individuals to seek to understand the impact of the trauma. And I think what this gets at is, I don't know if any of you have read or heard reviews or Oprah Winfrey or Dr. Bruce Perry recently talk about their book that just came out, What Happened to You, which is very much speaking to kind of the neurobiology and the impact of trauma. It's the trauma-informed approach is asking that what happened to you, seeking to understand that behavior in a non-pathological way rather than what's wrong with you. And so the trauma-informed approach is this idea that you can walk into any room with any individual, that the trauma history doesn't need to be present, and you're seeking to understand that person within their context, within their early experiences, family background, cultural context, and it just provides an overall sensitive care. And if there is a trauma history present, seeking to understand those behaviors and presenting concerns while taking care to not inadvertently re-traumatize the individual in questioning, in the treatment planning, and things like that. So the stages of recovery is very much a trauma-informed, trauma-sensitive approach. And I jump in too, I just want to say for this training, do what you need to do to take care of yourself. So if you feel more comfortable with your video on or video off, if there are times where you need to take a step away from the training and come back, please do what you need to do to take care of yourself. And we'll talk a little bit too about just the importance of taking care of yourself as a clinician while doing this work. So of Herman's stages of recovery are empowerment. If the core experiences of psychological trauma are disempowerment and disconnection, that is going to take place is going to be based upon the empowerment. I'm so sorry. Based upon the empowerment of the individual and connection. So that therapeutic relationship is going to play a critical role in that reconnection. It's also important, again, nothing happens in a vacuum, to understand different identity variables, cultural backgrounds, and early experiences that this individual has had. I really like the definition of empowerment. This is from the APA Handbook on Trauma, that it's an iterative process in which a person who comes into that space lacking power sets a personally meaningful goal, so a goal that the clinician has or a wish that a family member may have for that individual, but a personally meaningful goal oriented toward increasing power, taking action toward that goal, and observing and reflecting on the effect of this action, all while increasing self-efficacy, knowledge, and competency related to that goal. So as you think about working with individuals with a sexual trauma history or a concern that is their presenting concern coming in, at every turn, you want to be thinking about how to empower the individual and increase autonomy. And that comes down to choices. So very meaningful but small things that can be done at the onset is, this is a throwback to kind of when we were in person, but if somebody comes into the room and it's not against policies of your own safety, having that individual make themselves comfortable by choosing the seat that they sit in. So offering that choice. If that is not possible within the system that you're working in, asking the individual, to give themselves time to make themselves comfortable, giving themselves allowing that permission of things can be moved, pillows can be moved, the tissues are over here, and just providing like a conformed consent layout of the room, and if they need something how to access that. Another way to provide choice very early on is just asking how the individual prefers to be referred to by you. Is it the name that they have on the paperwork? Is there another name that they feel more comfortable being referred to that they would like to establish that relationship? Do they have pronouns? If that's not something that's being asked about on paperwork, to have a conversation about that to make sure that they feel seen, heard, and valued and empowered in the space early on. Something that is really important is that therapeutic relationship. So I'll share a little bit about my kind of theoretical orientation and background, recognizing that we all have our own theoretical orientation and back. Some of the examples that I might share may not resonate with you, but thinking about ways that using your own theoretical orientation and approach to the therapy work, how you can take these things and utilize in that person. And so with every client that I meet with at intake, I'm thinking about how to empower that individual. What are they walking into the room with and their experiences, and how do we work together to establish that collaborative therapeutic relationship. A really important piece about trauma work and that therapeutic relationship is transparency. So there's a shared understanding, and the individual that you're working with understands the choices that you're making in that treatment plan, and that there's a clear therapy contract about what that individual can expect in the therapeutic relationship. And so part includes how long are your sessions? Today we'll be meeting for 60 minutes, but ongoing sessions will meet for 45 minutes or whatever, again, your policy is. And be clear about the time, and as much as you can sticking to that time. What are the expectations? What can that individual expect between sessions if they need to cancel or reschedule? Who do they contact? What form of technology are they using? Do they call the front desk and talk to somebody else? Do they email you? If they email you in between sessions, really upset, do they expect a response from you? And being really clear from the offset. So I'll often share that a client can email me in between sessions, but only for the purposes of rescheduling. I'll refer them to after hour service, emergency services, if they need additional support, and we'll go over how to access that. But that our only therapeutic contact is happening in the agreed upon sessions that we schedule. That's once a week, twice a week, etc. I'll also have a conversation with each client in that first session about what they can expect from me as their clinician and my approach to therapy. So I'm very person-centered. I use a lot of interpersonal process in my work. We'll integrate DBT and ACT and CBT as helpful for the client, but really feel the here and now and therapeutic relationship, a lot of healing can happen when that trust and connection is established. So my approach to therapy, I use a lot of analogies and metaphors, and I will share one from the is that recognizing that I walk into the room with my own experiences and background, and the client is walking into the room with their own experiences and background. And they're the expert of their own story. And I have expertise that I hope can help them heal on their journey toward thriving and flourishing. If therapy is this situation where the person in the room is lost in the woods and they have their survival backpack that is packed with their tools that they've picked up along the way that are very much individually curated by their experiences. And I'm in to the space that they're lost in the woods with my own survivor backpack, with my own tools and skills that are both informed by my own life experiences, but then also the training and education as a psychologist. I have a flashlight, this expertise. And so as we're working our way out of the woods together collaboratively, there will be times where I shine this flashlight on things that I believe in our work together may be important to examine, process, look at before we can move on down the road. And there may be times in this process where I'm shining this hypothetical flashlight, like this is not part of my story, this isn't relevant given my experiences. And I want them to know that they can tell me that we can have a conversation if there are times where they feel misunderstood or I'm jumping or something isn't fitting, because the relationship between the two of us is really important. And if there is misunderstanding or feeling not heard, that needs to be addressed. So the goal is for us to get out of the woods together, and we come in with different survival backpacks and these two flashlights, and mine is lit a little bit differently because of my background, and my hope is that we can I'll also share with someone if there are things from the beginning that would be helpful for me to know about them to safety in the space. If it's in the physical room, if it's in the virtual space that we're creating, if there are important things for me to know. I have especially found this past year with telehealth that there can be a lot of things missed about a person that can be helpful to know, or that people have shared with me later on in session. So someone shared me that like they were very, very tall, and that was factoring into a lot of some of the relational concerns that they were having and social anxiety. And so that would be helpful for me to know when challenging some irrational thoughts, like what is based in reality and what is irrational. So that's a small example from a case with social anxiety. So asking if the client wants to share anything that would be help increase safety, and then is someone who will use self-disclosure. I'll ask if a client has any questions or concerns that they have for me that I can answer at that, again, help increase a sense of safety and connection in this space. The other thing about kind of the therapeutic relationship is just recognizing that with the work with sexual trauma, that there can be transference and countertransference. And so very similar to how healing for an individual cannot happen without empowerment and connection, I feel like the clinician doing the work also needs that connection and support and empowerment. And so thinking about your own boundaries and people that you can talk to, consult with, supervision, so that you're taking care of yourself to be able to best show up in the room and be present with the client. As the relationship goes on, something else that can sometimes help to have a direct and clear conversation about is the importance of truth-telling and disclosure, and recognizing that will happen more naturally as trust and rapport is established established, and on the person's, history, that may take some time. But recognizing that it can be, there have been times where a client may say, I haven't shared this with anyone else. Maybe some of you have had this experience too, where you're not feeling like the client is actually sharing that much. Like there's still some vagueness to the story. It's like a foggy, granular picture. And you're like, well, I'm the person that knows the most, and I'm feeling like I don't actually know much. How helpful can I be in navigating us out of the woods together? And so there will be times where I'll have a conversation with a client where they may end something with, and I'll share like, well, actually, I don't know. And it sounds like it would be helpful for me to know a little bit more. And so what at this point would be helpful to know about this situation, so we can work together to have a better understanding. So those are the three main principles that are going to inform the three stages of recovery. And I think as a clinician who is person-centered, and I think it's important to be culturally sensitive and understanding the person and all of their experiences. These are three principles of just my clinical work as well. And so I know that you all were able to have access to Herman's Trauma and Recovery book. I highly recommend, I think it's a great resource. She posits that there's three main stages of recovery for sexual healing, and we're going to spend the majority of today talking about establishing safety and what that means. Stage 2 is remembrance and mourning, and I think this is the stage where most people stereotypically can think about like what it means to do trauma work in terms of processing the narrative in depth and integrating that story so that it allows that individual to move forward to stage 3 with reconnection. And just wanting to underscore that stage 1, that establishing safety piece, is doing trauma work. It's doing really important trauma work. And that foundation needs to be laid for being able to move into doing any further processing. I remember as a beginning clinician wanting really clear direction on how many sessions do you spend in stage 1 and how many sessions do you spend in stage 2, and like what are the indicators that we move from stage to stage. And I think like anything in mental health, it depends. Like anything in life, movement through the stages are not linear. So it could be possible that you're moving out of stage 1 and establishing safety, and a court date comes up and there needs to be a revisitation of safety and taking time away from doing more active processing. I really like this quote from Herman's book that a therapist suggested that movement through the stages is like a skill in which earlier issues are continually revisited on a higher level of integration, which I think is really true. And so I've said this a lot already today, but what does it mean by safety? And so I think the first kind of piece is the sense of physical safety in an individual's life, emotional and psychological safety, and then also logical safety, and more at that neurobiological level, which I think is getting more, I think there's more and more research coming out about the importance of that. The other piece is that looking at safety both, so in all of those domains, both from the external threat to the individual, but also the internal threat. So the importance of feeling safe in one's body, and recognizing that you may be sitting with someone and it may not be possible to feel fully safe, and to validate that, that depending on the environment that the person is going back, depending on the recency of the event. That person may be in a hyper aroused state and may have a really hard time feeling safe. And just validating that it's normal to feel anxious in that initial appointment. It's normal to feel anxious when thinking about talking about traumatic events. And part of your work in establishing safety is to validate the individual's feelings, experiences, and being with the individual in that space. I think part of establishing safety too is establishing trust between you and that individual. I think it's understandable, very common for individuals who have experienced a traumatic event to come in and have their worldview shifted. The world is no longer a safe space, that they can't trust anyone, that they have to completely rely on themselves. And so having a conversation about your role as, your role is not to rescue. Your role is really to be there, provide knowledge and psychoeducation, and help them move through the stages, but that you're going to be with them kind of process. Explaining the approach, the importance of establishing safety, both in the room between you two, but also in the person's life. So what are kind of the early treatment considerations when we're talking about safety? So the first one is just depending on recency of the traumatic event that the person might have experienced, is medical care. So ideally a SANE exam, which can only be done at by nurses who are and are offered at hospitals and ERs. And I know in my community, there's been issues with SANE coverage at the hospital. So ideally a SANE exam is completed within 72 hours. And so having a conversation about if that's something that the individual is interested in. I think this early on in treatment, there's also plenty of opportunities to revisit that choice. I think, just recognizing what happens on a neurobiological level, making decisions, the feelings of ambivalence and conflict, it can be really hard to make decisions. And it's important that the provider doesn't step in and make the decision. That again, your role is to sit down, talk about the options, and refer to a victim advocate to talk about options if they are legal proceedings or other reporting measures to be taken, but that to be very clear that there's no wrong choice. That the most important thing is that the individual who has experienced the trauma makes the choice and not anyone else. And I think very early on, well-intentioned friends can come in and want to make an individual feel better, because we all want people, of course, to feel better and feel safe. And in trying to help take away choice. And so having remembering at every turn, the most important thing is, are we increasing autonomy, and does this person has in this room here with me? The next piece that is really important is, if we're talking about establishment of safety to then do processing, if we're building a house and establishing safety is the foundation and the wiring and the basement. And kind of in a parallel, when we think about feeling safe in one's body, it's really important to think about the very bottom of the pyramid, physiological needs of Maslow's hierarchy. And so trauma can bodily rhythms, and it's really important to reestablish body integrity. So that includes, regulating eating, regulating sleeping, and helping that individual hyperarousal symptoms or intrusive symptoms, and kind of return to baseline if it's from a hyperaroused, hypervigilant state, or from a hypoaroused, more flat. And so Herman suggests that you start right with the internal threat and think about bodily integrity and managing that before moving out to establishing environment. I think this is a bit of a chicken or egg situation, where recognizing that you might only be with an individual for, say, 50 minutes, maybe more a week. If they're then leaving your office and going back to an environment that is chaotic or unsafe, it's going to be really hard to sleep or eat or focus on basic care. And so I think in collaborative conversation and assessment of the client with the client and the environment, you may decide as the clinician that the priority after making a decision around medical is reestablishing a safer environment. And that may mean making some living adjustments. That might mean rearranging. So I've worked with clients before, who are unable to move and are having, intrusive memories and flashbacks and nightmares at night, and having a conversation about what would it be like to rearrange your room so it looks and feels like a different space. Recognizing that trauma memories are stored differently as images and smells and very vivid sensory pieces. Also thinking about are there things that can be adjusted or shifted environment that can change that? So is there a new candle that you can go buy with a different scent? Is there new linens that would help create some separations, like you're returning to the location of where you were assaulted? Is there realistic shifts that you can think about within the environment, thinking about kind of all five senses? So I think rearranging the room can be helpful, thinking about getting new linens if possible. And if thinking about smell, if there's something that can be added or taken away from that space, can be helpful. There may be even a conversation about kind of those pieces in meeting virtually. What are things that need to happen to make this 50 minutes feel safe? And is it a rearrangement of furniture in your space? Is it going to light a candle and have this scent be this is my therapy time and my time for myself? Is it I'm going to close out all the tabs and only have the Zoom meeting on, so I'm not alerted or notified by friends or families if the time is uninterrupted? The other thing early on in treatment is just that knowledge is power, and sharing, the importance of sharing what you know with the individual. And so I had sent out some handouts that we often use early on in treatment that feel free to adapt and utilize. But the two most common handouts that I'll go over with somebody in that first session is the responding to traumatic events. I think it can be, I've heard from many people, right? Like, I feel like I feel like I'm losing my mind. I'm very alone. No one understands. Just validating that the individual is not going crazy. They are having a very normal response to a very abnormal traumatic event. And so, if anything, right, their threat system is online and very active and works. And your work early on will be how to turn that alarm system off when they are safe. And so, just going over the common symptoms that someone may experience following a trauma can be really validating in recognizing that other people have experienced this. I'm not alone in this, and that I'm right. No one's losing their mind. No one's crazy. The other thing that is a crucial piece around safety is assessing important relationships in an individual's life. So as mentioned earlier, healing cannot happen without connection. And so early on, having a conversation about who is in this person's life that they feel safe around, who is in this person's life that can offer practical help, like if it is dropping off food or being that person that they can do as a distraction, but not necessarily have to talk about anything, who can make phone calls, and then who in this person's life is a potential threat or danger. And so how do we make a plan to create space, set boundaries, and protect so that relationship doesn't have to be kind of an ongoing reminder or ongoing kind of activator of the threat system in one's body. Another handout that I think can be really helpful to go over early on intake is grounding techniques. Recognizing that someone may come in a hyper-aroused, hyper-vigilant state, which makes a lot of sense. Grounding can help, again, just regulate back to baseline. With individuals with a sexual trauma background, the typical grounding techniques of deep breathing or closing your eyes may not be the most helpful depending on the individual and may actually activate or trigger a trauma response. And so some people early on in treatment, having grounding focused on the external can be more helpful. So giving someone the option as you guide them through a grounding exercise to leave them open and make themselves feel comfortable, and then to bring attention to the sounds that they notice in the room and have them name the sounds to you. If it is taking their phone as a reminder of the time and the date, like this is the here and now. If it's, again, bringing kind of awareness to their surroundings and visually naming 5 things in the room, 4 things that they can hear, 3 things that they can smell. If it's bringing awareness to how their feet feel on the ground, but again, thinking about kind of external anchors so that if they are feeling dysregulated in their body, that the attention and mindful moment isn't bringing more awareness or activating a trauma response in that way. Are there questions or reflections so far?
So you actually have two in the chat. The first one was, well, they both are kind of similar. A lot of sexual trauma survivors, some have difficulty with following through or continuing needing therapy. They come for 2 sessions, they miss 3. How do the stages of recovery inform how we manage that, especially if we have no show policies in place that dictate how many sessions one can miss before they're discharged?
Yeah, I think that's a really good one. I think sometimes someone can come in and there can be, I guess they have a couple things I want to share. Sometimes I think what can happen is going back to our role as not the fixer and not the rescuer. And when we think about what we're first doing in establishing safety, let's look at eating, let's make sure you're drinking enough water, sleeping, things that may feel away from the trauma but are really important to establish. Work is going to be happening outside of session. And so I think it can be common for it to be really hard to follow through if they don't have the or a safe environment. And there might be, I know at times, like I can have the experience, right, of feeling that resistance or have resentment expressed toward me that I'm not stepping in and doing more to help them feel safe. And having a conversation about the responsibility within that therapy contract of that I can help guide and provide guidance in this, but at the end of the day, because this is about empowerment and increasing autonomy, the individual is responsible for establishing safety. And what you as the clinician testing may not feel good. These are, healthy, coping, self-regulating, self-soothing things that one may not model to the individual depending on their early experiences. And if they are, engaging in more self-destructive behavior or to numb out and not have to think of trauma, a regular eating schedule and sleep is not going to give the same, it's not going to provide the same relief from the trauma symptoms. And the reality, it's healthier and more sustainable and is more, stepping toward healing, but it's not going to provide that quick fix. And so sometimes I think having a conversation very early about what someone can expect from treatment and the focus of treatment, that an individual may come in and feel pressure to share their whole story and have told it, and then they can be done and get on with it. That it's really important and you want to hear that story and be there for them. But for that to happen, the safety needs need to be met. So it might feel like you're running a marathon and you're focused on the first pacing of that 5K, and that those initial sessions are going to be very almost CBT oriented as you think about self-care. Then there may need to be like a conversation around what's leading to the no-shows. Is it transportation issues? Is it work schedule issues? And what a conversation on kind of that environment and what needs to shift so someone can keep their appointments because of the contract in place around the no-show policies. And then also having a conversation too, I mentioned that I tend to use a lot of metaphors in my work. If someone is ready to do the work. And so we're in the room together and we have this metaphorical house, and in the house, in the basement, is this box that is chaotically packed with this person's trauma. And in that first session, as the clinician, and I'm outside of the house with the client, who might also be standing outside of the house as well because they don't want to go into the house, or maybe they're in a different room in the house, and maybe their box in the basement is causing a lot of distress, and having a conversation about the work that could be done outside of the house first, that we don't actually need to pack the box right now, that we can acknowledge that the box is there, that at some point that box needs to be unpacked. But for now, outside the house, let's think about pushing safety and letting the client know that focusing on routines and physiological needs being met and support is doing the work. It's just going to look and feel different than when, as the clinician, you may have in mind like stage 2. I think too, there's a general approach and avoid that can be present in this space when working with individuals with a trauma history. And so acknowledging that dynamic early on, as you notice it with the client, that there may be times, right, where I don't know who's had the experience of you have like a really good, rich session with a client and you feel like, oh, this like was a missing puzzle piece and I understand this and I can't wait to keep doing this next week. And then next week, either the client no shows or the client comes and like all they want to talk about is, I don't know, like how irritated they were that their coffee order got mixed up or something like that. And it's superficial and surface level and it just doesn't, it's unfulfilling following such a rich session. And acknowledge and having a conversation with the client that there may be this approach that happens where someone really goes in deep with you and talks about the relationships that they have and who is in their support, feeling really good about like making sure they're drinking enough water and engaging in grounding and feeling regulated, and then they may fall off. And giving the client permission that, like I've had conversations with clients before where you have permission, like we don't have to talk about the trauma every time. So we may have a really good session. We may be making really good progress in safety. And then maybe there's an argument and something else has happened in your life. And we do talk about that. We can do that. We don't have to dive deep and talk about trauma every single time we meet, and kind of allowing some of that dynamic of approach and avoid to happen, and that the client is the driver of the bus. So if there are times where, I've had people come in and be like, I have an important work meeting and I cannot touch this. Letting them know that they can still come in, and maybe the way that hour looks is focused differently, especially if they have something important afterwards or something going on that week. And to give yourself permission as the clinician to be flexible within what work looks like. I feel like I just went on a long ramble, but my hope was that the takeaway was acknowledging kind of the approach and avoidance that can happen, and having a conversation early on about why it makes sense, why someone with a history of trauma will approach and then want to back away. And asserting yourself as someone who is a trustworthy guide that can sit. And there are going to be times where doing the trauma work and even establishing safety is going to look and feel a little bit different. And I think that's sometimes where I find the house analogy helpful. I feel like a client is kind of all over the place after a rich, deep session, or I feel like we've been making some progress. I'll ask them, like, where are we in the house? Are we even in the house? What would it be like to step inside the house? Oh, that's not something that can happen today. What needs to be attended to outside of the house? So naming what's happening in the room in a way that engages and is collaborative and leads to conversation. And I think too, like, having, as I'm sure is mentioned, like in that intake session, a conversation about like theories of the system, right? And so what is your no-show policy? How to reconnect to treatment or other treatment options if they aren't able to keep up their end of the contract. Did that answer?
The person said thank you, so I think it answered it.
Oh.
I think you answered.
Okay. Sorry,
I've gotten some other
I can't
comments.
see the chat right now.
You're good. Some other comments, they're saying very person-centered, help with building rapport and creating a sense of that safe space. They like that. Somebody else said you're referencing restraining techniques as well as permission to avoid, hide, or conceal. One also needs to discuss how to deal with pressure from anger with the therapist and part of ground rules.
Yeah, I think it can be, I think with that transference and countertransference that can happen, at some point in the work, it may be that the client is reacting or interacting with you in a way that is either a pattern of earlier relationships or a way of asserting control and power in a way that they weren't able to in that traumatic event. And so if there are times where you feel as the clinician and kind of using your, clinician instinct and consultation that you feel like you may have been placed in the role of perpetrator, attacker, the person who caused harm, having a conversation, I think I rely heavily on supervision about what needs to shift, and also having an open conversation with the client about, again, revisiting what each person is responsible for. And that part of the work is that as the clinician, you're not responsible for, it's impossible. You're not Superman, you're not Superwoman, you're not a super non-binary superhero. You can't fix or rescue. And wondering and being curious with the client if some of the anger or some of the notes or some of the resistance to doing some of the homework or activities outside have anything to do with wanting to exert control over this space, and that you want the client to feel empowered and in control in the space, and what needs to shift in a way that feels healthier and more sustainable so that the client individual is moving towards what they have. I'll also sometimes have a conversation about wanting to make sure that we're on the same page and checking in with the individual. the same goals. Like if from the first session to a few sessions down, like I may see things or could see where this could go or could see where the client needs to spend working on, examining, figuring out. And I may feel pulled to have the client come meet me. But our role is to meet where they are at. And I think sometimes, and I know I've had the experience as a clinician where I'm working with someone who's engaged in the legal system, I'm working with someone who's engaged in a Title IX investigation, and the whole thing has been a re-traumatizing event. And the individual sitting with me feels helpless, like no one has her back. And like, what am I doing? Just sitting here listening and feeling kind of that parallel process of feeling helpless and wanting to do something, have the client feel better, and what can I do? And recognizing that, yeah, this is really hard work. And the systems are not set up. Just in reflecting on people that I've worked with who have engaged in pursuing a criminal investigation, like it's really hard, and validating and with the client and having boundaries. So having conversations around, what's tolerable and tolerated by you as the clinician in terms of how that anger is being expressed. Can we name that the anger is present and validate that anger? And like, what direction does that need to go? What are healthier ways of expressing that anger? And, recognizing that there's lots of things that go into ongoing treatment, but if there are ways that you can, as the clinician demonstrate like that boundary, which maybe hasn't been set before, and that you're still here to listen, that you're not going to tolerate the anger or maybe at times mistreatment or disrespectful interactions that can occur, but you still want to be there and you still want to hear their experiences and help them navigate. To be able to do that as part of this contract and agreement that you both entered into, you also need to be treated with respect.
And other people are just agreeing with what you had to say, saying that it allows them to develop a sense of control from multidimensional losses they might have experienced. And then somebody else also said it reminds them of the levels of validation from DBT.
And so I wanted to have just a conversation about considerations for establishing safety at intake, and just recognizing that I don't know what your paperwork or new client intake process looks like. I can share where at James Madison University, there's new client paperwork that a student will fill out that I will receive before I ever sit with the client. So this is some of the questions that are on that paperwork, and then how to kind of follow up and acknowledge that. So we have questions about the individual's military affiliation, or if their family was affiliated with the military, and if there were traumatic, stressful events related to their military involvement. If the individual has experienced unwanted sexual experiences, if they've experienced harassment and abuse, if they've experienced a PTSD experience or symptoms of, and there's some examples given. if the person has experienced harassment, discrimination, oppression due to perceived identities. And then this year, we've been asking if an individual is experiencing kind of stress or anxiety related to COVID-19. And so some of those are financial stress, job loss, insecurity, grief, and things like that. So when I sit down with a client, I'll have a sense of if any of these things are endorsed. I think, and some of you, I'm sure, have had this experience that someone can, I think having the paperwork for a person to fill out before speaking with somebody can be helpful, because there can be increase in less barriers in writing something down rather than being asked directly about it and then having to put voice to it. Especially as, research has shown when a trauma is occurring, Broca's area is shut down, which is the part of the brain that provides speech and language and words. And so even just recognizing that like there may be times when you're sitting down asking questions to a client that they really may not have the words for it. And so giving them time and space to sit with something can be helpful. And another question and this is a question from Herman that she suggests, is just a direct question, asking the client if they are presently living in fear of someone's violence or if they have ever lived at some time in the past. I think it's important that if somebody endorses something on the paperwork and that if they don't bring it up, which I think can be quite common, to acknowledge that you see that and that you acknowledge it. So there are times where I may sit with someone who has endorsed an unwanted sexual experience, and they may spend the time talking about increased anxiety, and they don't know why, but they're having these, they're just more anxious. And so I will, at a certain point, ask or inform them that I see that they've endorsed having an unwanted sexual experience, and if that's something that they, would like to talk about with a clinician or with myself, and have a conversation, or that I see that they endorse this. Do they have a sense that what they're coming in with and talking about, if it's related to what they've endorsed, if it's more historical, and just, again, like having that client feel seen, heard, that what they wrote down on that paper is important and that you're reading it. I think it can be, I'll say that the intakes that I have with people who have endorsed a sexual trauma do not look like my typical intake. So again, like our kind of structure is that at a typical intake, you're gathering some information about presenting concerns, some family history, some social, some substance use, making some goals, and you're kind of on your way, assessing risk. And my intakes with someone who has experienced a sexual trauma looks very different in that we may name kind of the sexual trauma and how it's causing distress, and if someone's having flashbacks or nightmares and they're not sleeping, and we'll assess, risk. And then I'll spend the majority of the session going over like just validating and providing psychoeducation. Like, yes, it makes sense that you're having nightmares. What can we do that we can do in your room to adjust? Yes, it makes sense that you want to be alone right now, or yes, it makes sense that you're terrified to be alone. Like, who is in your, who are people you can reach out to support? Recognizing that there's no, like, the person gets to decide if they want to disclose why they're currently distressed, that there's no expectation that disclosure has, that it's, again, up to their choice, but having a conversation about if they feel like disclosure could be helpful, who maybe are safer people to talk to. So I feel like typically an intake for me looks different. I may be bringing in those handouts, or virtually I've been emailing handouts afterwards, after we've reviewed them. And that the important piece, I once had like an early supervisor tell me, and I think this definitely applies here, but I think with any client, that the goal of the first session is to establish rapport and a sense of safety in the space, and assess for risk, and have them come back for the second session. If you don't gather all of the detailed family history or employment history or specific details about their weekly substance use, as long as they come back for the second session, like, you can continue to build on that narrative and information to inform your consultation and treatment plan. That as long as you're establishing rapport, assessing for risk, and then I think, instilling hope, and in these cases, I think really validating that they're not losing their mind. These are normal responses to a very abnormal event, can be helpful, and recognizing that that this is something that you've seen before and worked with before, and that with time and work, these things can decrease. So I think as well, I typically will introduce grounding strategies in session for someone to practice on their own. And so we'll spend time in session, really guiding them through it to, one, get a sense of what feels safe for them, and two, wanting to instill some confidence that they can do it on their own, while also providing just the acknowledgement that it's really hard to learn anything new or practice anything new when you're under distress or really anxious. So, if you have a glass of water, like, it's kind of spilling over, so it's going to be hard to try these new things. And just to give yourself permission to experiment, and approach it like, we're just going to figure out, like, what doesn't work, what doesn't feel good, and maybe what will feel good. That having someone, name 5 things in their surroundings likely won't provide immediate sense of relief, but it will provide a sense of, I am here in this moment, and in this moment I'm safe. Probably not the same sensation as numbing feelings. If anything, it's providing kind of that foundation to be able to approach feelings, which, someone may be wanting to avoid. So just having an honest conversation about that none of these strategies are going to be this magic bullet, that we're just trying to add different tools that maybe you haven't used before to your survival pack as we're working our way out of these lost woods. I think the other thing too that's really important is pacing of the session, both at intake, but then also in ongoing sessions as well. And that, so if the client is the driver of the bus and has power and control in that way, your guide is kind of the co-driver, is make sure that you're pacing sessions. And so I typically like to start sessions, and again, this is just kind of more my own personal approach, with some type of transitional exercise so that a person can leave and transition from whatever they came from to arrive in the space and be present in their time. It also, as a clinician, helps transition to this session from whatever session or meeting I may be coming from. And then spending some time, if it is early on, talking about, what worked and what didn't work, how are some of the goals or safety going. And then if there were events that, occurred in the last week or 2 weeks that were triggering, if an individual ran into or saw the person that caused harm, having some time to really process and talk through that event and offer validation and go over options as needed. And spending the last 10 minutes or so of session really wrapping things up and engaging perhaps in another grounding, or if there's something the client kind of agree on how they want to end session. I had one client really like ending session with just playing a song. This was when we were meeting virtually, that it was kind of her outro song that just was a reminder that she can leave everything that we're talking about in this space, even though it's in the same room that she's doing work, in this virtual space. And now she's kind of going on about her day. So again, also moments where you can have a conversation about choice and what the client wants. And you as the having this expertise, knowing that it can be helpful to have a into enough time to process and time to transition out. So somebody isn't walking out of session like a raw nerve and completely dysregulated. So I'm using the house in the box analogy again. If we acknowledge that the box is in the room and maybe we take a peek underneath the box, making sure at the end of the session, it's wrapped up again, is everything back in the box? You can leave the box in the corner here, go about your day, and the box will be here next week. Can be helpful. There's also times I think where clients with pressured speech and really just want to share. I was once working with someone who came in a few sessions in and just was I'm just going to tell you everything and process everything, because I just want this to be over. And so she started to speak very quickly about the event and share details. And I paused and asked her kind of why she felt the need, there seemed to be some pressure that she felt the need to share everything today in this one session, and what that was about. And having a discussion about how she is doing work in the things that we're talking about, and that she can share with me as little or as much as she wants. And I want to make sure it's done in such a way that is that she can be in a regulated, calm state and not dysregulated. Which I think then brings up the point too, if you're pausing or interrupting clients, that I have learned by experience that it can be easier to do that when you have a conversation with the client early on, but that may be something that you do. That you may pause for clarity or some additional questions or redirect, and that you have the client's best interest in mind as you're doing that. So I'm just gonna and see if there are questions or reflections from this point.
I don't see anything in the chat, but we can give it another 60 seconds if you want to.
Okay. Well, what I'll do is I'll go to the next slide. At the bottom here, the utilizing grounding strategies, if needed to help guide a client, notes both out of that hyperarousal state, but also the hypoarousal state. And so I think it can be helpful just to briefly look at the polyvagal chart and polyvagal theory, which has been around for a while. And again, I think has been more and more research about the neurobiology of trauma and how trauma really, our brain is very plastic and will adapt and change to trauma. At a presentation last week about just increasing access and spaces on campus to students with neurodiversity, and the presenters mentioned then too, thinking about someone who's trauma is kind of being within the neurodiversity population because of the way, because there's just so much understanding of the way the brain responds to trauma. And so this is just at the 3 nervous system responses here. I really like this chart. I've used this chart in session with clients. Again, I think because it validates and normalizes their emotional response. And so the theory posits that instead of the 2 nervous system responses that were, typically taught in elementary and middle school, that there's 3 nervous system responses. The one being, the fight or flight, where their sympathetic nervous system is activated, and that's the sense of danger, kind of being in that highly vigilant, irritable, anxious state. Someone may have increased heart rate, blood pressure, sweaty palms, and just be on high alert. The freeze state is when the dorsal vagal nerve is activated. And as you can see here in this chart, that's showing like there is we move from danger to a real life-threatening situation. And so it can be common one to respond to trauma in that freeze state as a way of survival and taking care of themselves, and that can show up following the traumatic event in that non-depressed, flat affect way. So there can be times, I think, where someone may have incongruent mood and affect, or incongruent affect with content. And then the green here is the social engagement. So the idea that the ventral vagal is activated, and that there's more, you're activated, but there's a dynamic, flexible way to that activation, that you feel safe and regulated. So there's a calmness, a groundness, and in that there's a curiosity and openness, is ideal in being able to just thinking about therapy in general, can be helpful to be in that state. And so as you think of establishing safety, and if someone is wondering, why are we spending so much time on bodily integrity or establishing routine, I think sometimes this can be a helpful handout to share about the importance of feeling safe on a neurobiological, physiological level, so that we can sit with and difficult emotions without having to engage in self-destructive or unhealthy coping. And I know next week I'm also doing, we'll be talking more about eating as a way that I think can be a common safety behavior that people can engage in following a trauma to cope and get a sense of control. Just disordered behavior in general that can lead to, that can help a person numb out and avoid, which can be desired kind of in the immediate after effect. And if there are ways, right, that we can put aside the unhealthy behavior and coping and engage in something that leads someone more to the green area of safety. And then as you're thinking about kind of other safety concerns, as those things are established, part of the work is, an ongoing assessment of safety and future protection and assessing the environment. And then decisions regarding action against the perpetrator. I think having an open conversation about an informed consent about what it means, what it could mean to that sense of safety, and making plans when one is engaged in a criminal proceeding, and how are you taking care of yourself as you approach court dates, if it is connecting to a victim advocate in the community. Part of my, as the sexual trauma empowerment program coordinator at JMU, is also collaborating with our victim advocates who may be working with students. So I might be doing the therapy and clinical, and they would be engaged and connected with someone who is able to go to the police station with them to file a report, go to court dates with them, or go to Title IX if there's an ongoing Title IX investigation. I think it can be really helpful to collaborate. Again, typically there are some resources in the community, and I'm not aware of your region, but I'm sure victim advocates available, and I think they can be a really helpful referral source as part of the establishing safety. So I want to pause and take some time for questions, and then I would like to kind of transition to a case vignette and things, just having a conversation about what this means in kind of clinical application. And if there aren't any questions at this point in time, we can just transition to the case vignette.
I'm not seeing any relevance to what you discussed, so we can transition. That's fine.
Okay. So this is, I imagine that you have received this referral and am interested in, before you go and meet with this individual, what are some things that you are considering? So client identifies as a 38-year-old multiracial, cisgendered, hetero-Christian married woman. She reports that she has previously has engaged in therapy to address childhood trauma, and reports mixed feelings about past therapeutic engagement. They couldn't help me, I overwhelmed them. 6 months ago, she was physically assaulted and raped while leaving her office. After working, she reports experiencing recurrent intrusive memories of the event, nightmares, flashbacks, feeling shame and gross, withdrawing from others, and difficulty eating and sleeping. She reports that she feels like she is losing her mind and going crazy. So I would love to open this up just for conversation. If you want to either put it in the chat box or unmute yourself, just what are some things that you're thinking about as you are going into the office to meet with this individual. And I have a few other things on this slide, and then I'll stop sharing my screen. But until then, I can't see the text of the chat box.
I'll let you know if they may text anything. Some people are saying a lot of normalizing. Let her know she's not crazy. And they said they need to assess for suicide risk.
Mm-hmm.
I always find it really brave when people express a negative experience with therapy before, to be willing to come back, even if you felt like I was uncertain if this could help, and just kind of exploring how she even came to that decision, and getting back into this and what her expectations are, and also possibly acknowledging how far the work towards trauma-informed care has come since maybe she was in therapy, that maybe that therapist didn't understand all the how to help someone heal from childhood trauma. So
Yeah, thank you. Those are all great. It is really important to normalize, validate responses. This could be a point, right, where some of that session is spent on just psychoeducation and normalizing of common responses to trauma. Are there things about physical safety or environmental safety that come to mind as you think about this? And I guess I'll go ahead and just share the rest of what we know about this case. So her request to a transfer to a different office denied. She has not told anyone about the event, and shared concern that what occurred could be considered adultery. And then she blames herself for the event happening, pointing to the fact that she should have left the office at the end of the business day rather than staying late to work on a looming project. So kind of with this additional information, are there, what are you about when you think about priority of establishing safety, of establishing rapport, and working with this client? Are there other questions that come to mind or things that you want to know additional information about to be able to make those decisions? I will go ahead.
Somebody asked in the,
and
I was going to say, somebody asked in the chat if she was working at the same place still and was the perpetrator caught.
She is still working at the same place, and the perpetrator was not.
A couple people are mentioning the need to create a safe space for leaving the office and having a plan, walk out with somebody. Other people are saying share with her it's not her fault. Got a lot of typing going on.
And I can see the chat now, so this is great. I don't know what I've just done to change that. That is very helpful. Yeah, this is something that hasn't explicitly been said yet today, but the importance of validating that it is never the fault that another person chose to violate them, that they are not to blame, that I think there can be at times a lot of if I'm thinking, so if I had done this differently, if I had answered my phone at this time or done this differently, and just recognizing that there's, that it's a really terrible, awful feeling to have that control taken away and to be violated in such a manner, and that it's not the individual's person's fault any means.
So I have a question about that. With the ruminating, going over the what if I done this or done that, or do you get the sense that it's that person trying to recreate the scenario in a way that gives them back that sense of control, the wanting to have a do-over? And so from that standpoint, for the client, having this go round and round and round, it may make them feel like they're going crazy, but it's a normal reaction to have because your brain's trying to get that do-over.
Yeah, I think Susan, thank you. I think yes, I think that can definitely happen. And I think if you notice the rumination or circular thinking, if it is naming like the purpose or function of that thinking, to kind of reclaim the narrative and take control, and acknowledging that and the power of that, but also how is this serving you currently? So there may be a time, right, where the rumination or the magical thinking of if I had just done this differently, this wouldn't have happened, isn't working anymore. And, you know, let's create some space from let's put it a little bit and think about ways to kind of reclaim where do you have control in the now and how can we feel empowered in the now. That brings up a really good point. I think I worked with an individual who was continuing to have nightmares more often than not, like more nights a week than not, and flashback and like not getting any sleep. And so we were talking about her nighttime routine, and she shared that she really liked watching Law and Order, CSI, or a criminal show that in her mind was relaxing, because in that show, right, like by the end of the 50 minutes, the perpetrator is justice is served and it feels really good. And it was triggering flashbacks and causing nightmares from her own experience. And so acknowledging like that makes a lot of sense, that I want to have this story wrapped up within a concrete period of time and see justice be served, and it's not helping you anymore. What can we do differently where you can still feel kind of that empowerment and like in control in a way that's not setting you up for a restless, regulated night of sleep. I think too that gets at, I think it can be, you know, everybody, there are responses to trauma and everybody responds differently and makes meaning differently and has their worldview impacted differently. And so one person may, you know, withdraw and isolate and be fearful of, and another person may, you know, engage in more promiscuous, unsafe sex behavior in hopes of reclaiming that narrative or having the story end differently or power and control in that situation. And again, acknowledging the function and purpose of that behavior and not shaming that behavior, and also having an open conversation about how is this behavior serving her? Is this helping her heal? Is this helping her or him or them self-regulate, or just kind of thinking about that baseline green safety space? Are the ways that someone's taking care of themselves helping them toward that space, or are we stepping away into more of that yellow or red? I really like here that help her to understand that she is not responsible for the evil behaviors of others, and I don't think it should be viewed as adultery, and that she was not a willing participant. I think at times on some level that the fault is not theirs to hold. However, when choosing between feeling powerless over their safety and bodily autonomy and feeling ashamed, the latter feels less frightening. Yeah, I think that brings point two, that sometimes I'll have a conversation with someone about the self-blame, that in this situation, if they are to blame, that means that they can change something and go forward differently, so it doesn't happen again. It can be a really scary, helpless place to recognize that they aren't to blame, and therefore there's less control there. So acknowledging the function of the self-blame. I think too, with the adultery point, being sensitive of people's different faith backgrounds. This is something that's come up that I've worked with. I'll share kind of in consultation with individuals, I'll share like a different perspective on the 10 Commandments and why that is not, that God would not view it as adultery, given that it was a violation and the choice was taken from her.
That makes me think about a young woman I worked with once that, had not been in a relationship before, was raped. And so now was, one of the pieces that she was mourning is that she was not a virgin anymore. And so talking to her about that, she gets to determine the definition for herself. She gets to determine her identity, and that doesn't have to be true for her.
I think what's inherent in trauma work is the amount of work that you will be doing with an individual around grief and loss and managing that as you're moving forward through the stages, and also recognizing too for the clinician, how are you taking care of yourself and not bringing that home with you. And so there may be some parallel process of what you're doing with the client at the end of session in terms of visualizing this box in the middle of the room, now moving to the corner of what are you doing at the end of sessions or at the end of your day, where you can leave work at work as much as possible. I think there are, of course, cases that or maybe you're consulting more about and are on your mind more, and like the importance of having those emotional and physical boundaries for yourself as well. Guys talked about a lot, and I think this year, especially with everything on telehealth and working from home or working, the idea of boundaries has been really present. I know on my mind that my self-care is now very much defined by my boundaries and what my boundaries are. And I think it can sometimes be easier to set a boundary rather than enforce the boundary, but like really keeping the boundaries for myself. So if it is not checking your email for a certain time, but giving yourself permission to keep those boundaries. Yes. I think this is, so there seems to be so much going on that helping her prioritize which piece is the most distressing to her and continues to impact her functioning and well-being would be the most important starting point. And so to start with the steps toward that goal that she has power and excellent. Taking on all the secondary stressors from the trauma at once could be way too overwhelming. So I think, this is a case that, having ongoing conversations about is in this person's control. And depending on the day, that might just be like what she's eating in a healthy way, like keeping a regular eating, making sure she tries to get to bed at a reasonable time, and making sure she's drinking enough water and getting outside for some fresh air. So really, I don't want to like basic self-care, but like anything else can't happen without those things, and validating that those small things that I think can be easy to kind of have fall to the bottom of the priority list are the most important when thinking about establishing that foundation to be able to address the other stressors happening. I don't know if this was mentioned earlier in the chat and I missed it. I think someone had shared, creating a sense of safety when leaving, such as walking out with someone where she parks. I think too, if there is, having a conversation about what's realistic and shifting her own office, those ways to kind of create space from the event and what happened. If there are if there's a different entrance that she can use, it'd be a conversation about if it is adjusting work hours or if it is just sticking to those boundaries of giving herself permission to leave at the end of the business day and finishing up work from home if that feels safer. This case is based off of a variety of individuals that I've had the honor of working with in the past. And I'll share that with one individual that I'm about as I was putting together this presentation was that establishing safety piece took a really long time, in part because of the toxic work environment. And so part of our work together was empowering her to give herself permission to apply for other jobs. And it wasn't until, she was in an environment that we could even, that I was even considering stage 2 of processing trauma. Just recognizing how difficult it is to have to return to this site of the trauma most days of the week. And so sharing this too, also to give yourself permission that establishing safety piece is going to look and feel different with individual. And at times I think can be very, can feel like a grind and can be frustrating if there's this internal or external credit. The work needs to be more active or more narrative focused to give yourself permission and remind yourself that what you're doing is meeting the client where they're at and helping them establish a really healthy, sustainable foundation so that they are ready to enter the house and go down to the basement and unpack the box with you, or bring that back box up the stairs and into the light and sit with you and start to unpack it. So that in stage 2, that unpacking happens with that really strong foundation. And then as you move into, stage 3, repacking the box with a coherent narrative in a way that feels regulated and is integrated into this individual's story, but isn't the person's whole story. so that they can move forward and flourish and really thrive. I'm going to stop sharing my screen here. I just want to open it up. We have a few minutes left here. I really appreciate all of your time and participation. If there are questions, reflections, takeaways, hopes.
I have a question that's probably a little bit more down the road in therapy, but I'm curious on your thoughts. So, oftentimes when we work with people who are victims of sexual assault, it's not oftentimes like a random violent act. It's someone they know, a partner, a family member, a friend. I guess I just use an example. I have a 23-year-old client who was assaulted by her boyfriend when she was 16. She was unconscious at the time, and he was 23. So obvious wrongdoing there. She didn't know any better. She was 16. They continued on in the relationship for quite some time. They kind of ended up naturally separating from her going to college and things like that. And he's continued to reach out to her, and she's responded to him positively every time he did. So, some years passed, and, something clicked for her. She started to identify that as a trauma in her life. She sought out treatment, and she's been doing great. She did the safety planning stuff. She was able to kind of relieve some of her shame. But where she really struggles is she has this idea in her head of this is someone that really hurt me and betrayed me, and I'm really angry, but this is also my first love, and I still love him. So I'm wondering on your thoughts of how you kind of navigate that ambiguity for clients.
Yeah, I think, thank you for sharing. I really complexity. And I think, again, recognizing that each individual is coming in with their own story, and I wouldn't, but I think what comes to mind as I'm hearing this, how difficult that inner conflict must be, is just recognizing that, and I share this like with this case in mind, that someone doesn't have to be all good. So I think it's unfortunately common, right, that someone that we love deeply and care about and wish well for has also caused harm. And that we can space for the part of you that is hurt and mourning, that betrayal and that kind of abuse of trust. We can also, hold space for the 16-year-old part of you that loved this individual and have positive memories. And we also don't have to, as an older self, don't have to beat up on the 16-year-old self that I should have, quote unquote, known better. Like you, navigated and took care of yourself in the best way that you knew. We're in this relationship in the best way that you know how. And, maybe through our work together, we're working on advocating for yourself and putting voice to the things that you need or want in a healthy relationship. Don't have to, we can hold space for both of those. And it's really hard to hold space for both of those. And that if you're like, I can do that for you and we can do that together, like holding that space. But those can be situations with really complex grief.
I wanted to share, I guess, a concern of mine. More specifically, I had a client that I was working with that had some really complex trauma. And it was really I guess this was more so on my part, really difficult to really engage her. Like it was just really hard for me to like really feel like I was helping her like when I was doing the telehealth thing. Like I just felt like I just wanted to be there in person and really engage with her and make sure read her body language and everything. And you know, I always checked in and made sure she was okay, and never wanted to leave the session with any kind of wounds or anything open. And it was just one of those things where I found it really difficult to just um, be able to have that moment with the client, but virtually, and still feeling like I'm being supportive and you know being just a human with the relationship with building that rapport with my client. So that was something that, especially when I was working with trauma, with other clients, it was okay, but with my clients with trauma, it was just like I wanted to have that literally that in person. I'm right here with you, helping you walk through this. And it was something that was really difficult. That something I really had to kind of work through myself and with my supervisor as far as like being able to um, feel like I'm making an impact, even though this is a virtual relationship.
Yeah, thank you, Tiffany. I think this past year has been really hard, especially even just recognizing that trauma and high risk clients, right, aren't necessarily like it's not mental health generally, and we've had to pivot and provide our services via telehealth, and that it's been really hard. I think their power in being in the same space as someone and providing that just sense of connection and validation without any words being said, and how that's missed virtually. And just I know something that I co-facilitate the support group for survivors, and we made some adjustments our second semester, and had like little group kits of like grounding stones and colored pencils and some little mandalas that they could color, and just some little things and pick up from the desk, and then have and they could utilize those grounding like tangle toys or little stones that we had while group was happening, but also just to help kind of in group cohesion at that point, that they all had like the same like stress toy that they used. And I started doing that with some clients who were able to come into the office. Like I that because in my office I have all of those like stones, and I have things that clients can engage with that maybe I'll have to think about how to adjust with just COVID and like health hygiene. But that we could have a conversation about what can be present in this space to help establish that sense of cohesion and connection. And if it is like closing out all the tabs, putting the phones down, and helping the client just be present with you on the screen. And yes, it's something that I consulted about and sought support. I think there's so much power in the just being in the same room as someone who is suffering and in a lot of pain. My hope is that something from today's conversation was validating for your own experience as a clinician working with that you found something helpful to think about and something helpful to think about in terms of clinical application, even if it is just validating that, someone in pain and validating their how they're feeling is doing really important trauma work. Next week, I will be back. Really grateful for the opportunity to talk to you more specifically as I shared my interest in eating and body image concerns and the overlap with trauma, working with disorder behavior and sexual trauma, and kind of taking that lens of not pathologizing the behavior and understanding it kind of in the context of trauma, and how to help the client again make shifts, feeling safer in their body without engaging in self-harming or self-destructive behavior. So I will be here again next Wednesday at 1 o'clock. Thank you all for your time and your thoughtfulness. I hope you have a good rest of your week.